Good morning, everyone. It's wonderful to see some familiar names and some new names joining us today. I'm Dr. Tara Kiran. I'm a family doctor at the St. Michael's Hospital Academic Family Health Team and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. And I'm really delighted that our department is able to collaborate with the Ontario College of Family Physicians to host these community of practice sessions for family doctors. I'm going to turn it over to Dr. Jennifer Young, who's going to introduce the session.
Well, thanks, Karen, and thank you all for joining this really important session where this is the 8th time we've come together to discuss how we're managing, changing the way we work, the pivots that we're all making and have been for the last, if you can believe it, 6 months. I'd like to start the meeting with a land acknowledgement where we acknowledge that the land on which we're hosting this meeting is the traditional territory of many nations. We acknowledge that Ontario is home to many diverse First Nations, Inuit, and Métis peoples, and that each of you are joining us from one of those many traditional and treaty territories. We are grateful to be able to come together in this way.
The land acknowledgement is a wonderful time for us to also reflect on systemic injustices that the Indigenous people in Canada have had to face for years and continue to face, and our role in ameliorating these. So I just wanted to draw attention to an article that was published in CMHA in the spring, which I thought was excellent. And it really talked about Indigenous-led healthcare partnerships as a way for us to try and achieve better holistic health outcomes, potentially for our Indigenous populations. And so if you haven't seen this article, please do give it a look. I think that table 3 in particular has some wonderful suggestions. So today, I know many of us are gathered today because we are really nervous about going into the fall. We've had a tough spring. All of us have had to change the way we work, and change has become constant. And we're going to be talking about, some of the questions that you've raised, things that you're not sure how we should be approaching, and hopefully together we'll be able to leave this session a bit wiser, a bit more knowledgeable. We may not have all of the answers, but the way we've designed this community of practice is that it's an important forum for us to share and learn from each other. And if you'd like to check out our previous sessions, please do click on the link. And this session and all the resources we talk about here will be posted at that website afterward. I do want to give a shout out to our organizing committee who is responsible for planning these sessions and selecting the speakers. And today we have a wonderful panel for you. We've got our guests that are our usual guests, Dr. David Kaplan and Dr. Jennifer Young, as well as 2 special panelists, Dr. Jennifer Bondi and Dr. Jeff Kwong. So I'm going to turn it over to our speakers to introduce themselves and let us know what disclosures they have. Jennifer Bondi, do you want to go first?
Yeah, so thank you very much. My name is Jen Bondi. I practice comprehensive family medicine in 2 practices, one at a rural family health team in Amherstburg, Ontario, and at the other at the CMHA Health Center in Windsor. I am the current president of the Essex County Medical Society, and I've been the co-chair of the primary care pandemic planning team in Windsor and Essex.
Jeff?
Yeah, I'm Jeff Kwong. I'm a family physician at Toronto Western Family Health Team. I'm a clinician scientist, so 80% of the time I actually do research based at ICES and at Public Health Ontario. I'm an epidemiologist by training with an interest in influenza and other vaccine preventable diseases.
And so, as I mentioned, I'm Tara Kiran. I have a number of grants and salary awards from nonprofit organizations, but also have received grant money from Gilead Sciences for research related to curing hepatitis C. David Kaplan?
I'm David Kaplan. I'm a family doctor in North York in Toronto. I am an employee at Ontario Health, which is the super agency that was made up of the previous LINs and on Health Quality Ontario and Cancer Care Ontario and Trillium Gift of Life. I'm the Chief of Clinical Quality there, and I'm responsible also for the primary care quality file. And I receive an honoraria from the OCFP for this series.
Jennifer Young.
I'm Jennifer Young, family physician in Collingwood, Ontario, community and hospital-based, and president of the Ontario College of Family Physicians. I have received, I'm a speaker for the OCFP, but have been there since as president for the last coming up 2 years.
Thanks, Jennifer. And so, of course, we're delighted also to welcome all of you from the many places in Ontario that you're coming from. I want to, one of the things that I think makes this community practice special is your participation. So I'm just going to go over quickly how it is that you submit your questions. So with the Zoom webinar, of course, you can't speak live, but you can certainly send us your questions. So there's a Q&A box, and we encourage you in the Q&A box to type your question in there, and our panelists will either type the answer or indicate that they're going to answer it live, in which case I'll turn the question over to them. Sometimes during the course of the conversation, you yourself have links, suggestions, things that you want to share with other attendees, which we highly encourage, and please do go ahead and do that in the chat. So you won't be able to answer the questions in the Q&A yourself, only our panelists can, but you can certainly contribute to the discussion in terms of answers in the chat. But it's easier for us if you can put the questions in the Q&A. So, to begin, I'm going to start by we're going to start by hearing from Dr. Jeff Kwong. Jeff, I mean, we're lucky to have you today. You're a family doctor, but you're also a public health physician and a flu epidemiologist. And I know a lot of family doctors, and many who submitted questions prior to the webinar, had questions about how we're going to prepare for this fall, given that, we usually see lots of flu in the fall and URIs, and now we have the added complication of COVID-19. So what can we really expect out of a flu season while we have COVID-19 circulating, and how can we prepare for that? And of course, flu vaccination is also a big responsibility for family doctors, and how can we execute on that responsibility?
Yeah, thanks, Tara. So can I have the next slide, please? So I'll start with this table that many of you have probably seen. How do we distinguish between the new coronavirus versus the common cold versus influenza? And they've listed all these symptoms here and say which ones are more common or less common with each of these viruses. So the issue is that in the fall, in winter, we normally see a whole host of different viruses. So everyone always refers to influenza season, but it's probably more accurate to refer to it as respiratory virus season, because besides influenza, there are other respiratory viruses.
I think Dr. Kwong is frozen. Sometimes it took me a minute to make sure it wasn't my own screen. So we'll just send a message to him. And maybe I'll ask him to, while we're waiting for Jeff to unfreeze, I see that we already have a couple of questions that have come into the chat. And Jennifer, I know that there's one question there that related to masks, and people asking for notes to exempt them from using masks. And I wonder if you could speak to that issue. And Brian, I wonder if you could bring up our slide on masks on slide 27.
Sure. There are very few indications for refusing to use masks, and those are there on this slide. This is the Ontario guidance. Quebec has been braver in coming out and saying, really, the only people who can't use masks are ones who physically can't get them up to their face because of paralysis or facial deformities. The trouble breathing As you can see, the second bullet, it does say anybody who has trouble breathing, but that is different from what the Canadian Thoracic Society says about asthma and COPD. So I think, and I know this is a lot of, this is hard to do because it takes a lot of time. There is mask anxiety, and there's a video at the bottom there that helps people who have claustrophobic feelings around using masks. So if that's the reason for their not wanting to use masks, that's a tool you can direct them to. It's a 5-minute, essentially self-desensitization video done by a psychiatrist. It's quite nice. With regards to the exemption for asthma and COPD, I might suggest that that conversation might also be framed in that the masks will help to protect them from exposure. Not entirely, as we know that cloth masks are not perfect in protecting the mask wearer from getting exposed to viruses, but there is a degree of that.
Thanks, Jennifer.
I
think there's one follow-up question here about, is wearing a face shield an acceptable alternative for claustrophobic patients? I don't know.
Yeah. So Kate, I think that is an option that is being offered. And for example, children, that might be something that's easier for children to wear. And it is it's something.
So the only thing I would add, I see we got Jeff back, but the only thing I would add to that, that one of our colleagues had suggested to me yesterday, was that for some survivors of abuse or sexual abuse, a mask could also be triggering. And so just as family doctors, we're probably uniquely aware of our patients' backgrounds, but we may not. And so just an exploration, if somebody does come to you, that maybe there's another reason that a mask could be triggering for them, and trying to be supportive of that.
I wanted to just shout out to Michelle Griever, who is on the chat, just posted the link to a CFP publication systematic review around the risk reduction with masks. And she's put in, I think, one of the key paragraphs there. I don't think we're implying that face shields are a substitute for masks, Yunjin Park. I think it's just that is, if it's probably face shield is better than nothing, I think was what Jennifer Young was.
That's what I'm saying. And then Michelle, the systematic review that you're referring to is one around healthcare workers wearing surgical versus N95, and indicates that surgical is protection for that's my comment earlier was about community members wearing cloth masks. If somebody with asthma or COPD is able to wear a surgical mask, or somebody with that difficulty breathing can wear a surgical mask, those are, for one thing, often easier to tolerate, and they do protect the wearer from getting viral infections. So I would like to re-emphasize my earlier comment around not protecting the wearer is about cloth masks. If they're wearing a surgical mask, it does protect them as well. A, it's easier to breathe through them, and B, it protects them. So it could be a plug for the individual to, encouragement for the individual to wear that mask.
Thanks, Jennifer. So I see that Dr. Jeff Kwong is back. And so we're gonna go back to his slides. I see that there are also some questions about flu, so I think it's good timing.
Okay. Yeah, really sorry about that. I guess the Wi-Fi cut out for me here in the hospital. I'm just going to ask for the next slide, please. So, so one thing is that, there's been a lot of controversy about whether the new coronavirus can cause asymptomatic infection. And what's probably less known is that influenza and other respiratory viruses also can cause asymptomatic infection. So it's probably not that surprising that it's very possible for, COVID to cause asymptomatic infection. And this is a nice review study that one of my favorites, where they reviewed 56 volunteer challenge studies. So if you can imagine, almost more than 1,200 people subjected themselves to getting infected with influenza. And then they studied them over time and to see, looking at the viral shedding patterns and their symptoms. And you can see that the viral shedding increases, within a half to 1 day after the challenge, and it peaks on day 2. whereas the symptoms increase on day 1 and peak at day 3. So this whole thing about like pre-symptomatic infection is actually well known for other respiratory viruses and shouldn't be that surprising for COVID. And for symptomatic infection, they only saw symptomatic infection in 67% of those who were infected with influenza. So roughly 1/3, at least in this study, had asymptomatic infection when they were infected with influenza. And they only saw fever in about 1/3 if there was like H1N1 infection, and maybe a little bit higher, 41% for H3N2, and then lower for influenza B at only 8%. So I think we can remember this as a rule of thirds. Like 1/3 of people will have the classic, influenza-like illness with fever, cough, etc. 1/3 will have, what we might call as just a cold, where they may have some symptoms, rhinorrhea, whatever, cough, but no fever. And then the other third could have asymptomatic infection. And I think this is why influenza is so hard to control. It's like, even though there's a lot of people getting flu shots, but there's, I think, a lot of pre-symptomatic or, like not very severely sick people going around and spreading it. So hopefully we can avoid that this year. And I'm going to ask for the next slide, please. If we look at what's happening, so I'm going to first talk about what we know about COVID in terms of the R0, or the reproductive number. So the estimates of R0, or the reproductive number, is about 2.2 to 2.7. And so that means that for every infection, every COVID case, they're going to infect on average another 2 to 3 people. This is on average, so sometimes they go on to infect no other people, and sometimes there could be super spread events where they infect many other people. But this is a modeling study where they looked at the potential impact of a bunch of different public health interventions, so such as school closures, physical distancing, etc. And in this model, they estimated that by combining all of these features, they can bring the R effective down to like 1 point something. And so, bringing it down from like around 2.7 down to 1 point something is, quite a big drop. And it actually takes lockdowns to bring it down below 1. But the idea here is that, we know that seasonal influenza has an R of about 1.2. And so if we're actually have all these measures against COVID, we could actually bring down the R for influenza down to around 0. So I'm going to ask for the next slide. And so this is what's happening in Australia. We're actually seeing, you can see here, this is the number of lab confirmed cases of influenza for the last, from 2015 to 2019, and then this year. And so you can see the yellow line there, it is the 5-year average from the previous 5 seasons. And so it normally peaks around August or September. So like right around now in Australia. Last year in 2019, they actually had an early season. So you can see that curve where it comes up earlier. And then in 2020, which is the red line, you can see that it was tracking along the same path as 2019 up until March. And that's when, WHO, announced, declared the pandemic, COVID-19 to be a pandemic. And then, everyone introduced lockdown measures, and you can see that the number of cases of influenza dropped, down to basically 0, and has stayed at that level, since then. And so this is not just for lab confirmed influenza cases, but if you go to the next slide, we can see, for influenza hospitalizations in the 2020, the solid red line is, stayed at the bottom from March until present. So they really haven't seen any influenza activity in Australia. I think the same has been true for all the Southern Hemisphere countries. So hopefully that bodes well for us if we can maintain our current physical distancing measures, hand hygiene, etc. Hopefully we'll be able to avoid a lot of the respiratory activity that we typically see in the fall and the winter. So I'm just going to ask for the next slide. So I'm just going to end my piece here. This is some excellent guidance that was released by the National Advisory Committee on Immunization, or NACI, where they talked about providing some guidance on how do we deliver influenza vaccines in the presence of COVID-19. And it's just chock full of very practical tips on how to do your clinics. So things like you should maybe set up appointments or do your flu clinics outdoors in parking lots if possible. have like drive-through immunization clinics. How do you physical distance people, and you have to, take into account, that 15-minute period, observation period, you have to make sure there's not too many people in the room, having hand sanitizer everywhere. So lots of practical tips in there. It's not a very long document. The link is there. And I highly encourage you, if you are doing influenza vaccination this fall, to take a quick look at it. So those are, that's, my response to your question, Tara.
Jeff, can I ask you 2 questions?
Yeah. Yes.
I'm gonna ask 2 pointed questions that I know are probably on people's minds. So when we look at that influenza rates in Australia, that was with schools open or closed in Australia?
I believe they were closed because I think that's their summer holidays.
Over the winter?
Yeah, in the winter. Yeah, if I'm not mistaken.
So I think that would be interesting. And then the other thing is, can you comment on the 15-minute wait time post-vaccine? A lot of our colleagues, I think, are thinking about drive-through vaccine clinics. I think we actually had a question maybe about that somewhere in the chat or communicated to us earlier. I think it would just be really interesting to get some clarity on whether or not that you could safely do a drive-through vaccine clinic.
Well, I think the idea is that you have to have like a parking area for people to wait after they receive the vaccine, just to make sure they're not going to have an anaphylactic reaction. I think that would be the prudent thing to do. And I think that's part of the logistical considerations, of when you pick your site, you have to have a place where people can wait after.
Thanks.
Yeah.
Brian, I think there's actually a slide that we have about drive-through vaccination clinics. So maybe we can just put that up, and I think there's a resource, just after this one. I think, was it you, David, who suggested this resource? But anyway, there's some guidance here around drive-through vaccination clinics that we'll post in the chat. Jeff, I think there was another follow-up question about, what related to the really striking graph that you showed about flu rates in Australia. What percentage of the population in Australia was immunized for influenza in 2020?
Yeah, I don't know the exact number, but I do know that there was increased demand, so higher than the usual for them. So I don't know if it was, 30, 40, or 50%, maybe, potentially higher, but I doubt that it would be higher than 50%. I don't think that there are too many places in the world that have achieved more than 50% of the entire population getting vaccinated. Likely higher for high risk groups. We are able to get into the 70%, in high risk groups. But not for the entire population. But probably that contributed as well. And so that's why I think, it's a good idea for everyone to get vaccinated this fall, because it's something that we do have and something we can try to avoid, at least the influenza activity.
So I should say, just to add to that, so the Ontario government is actually trying to procure additional vaccine doses, knowing that the uptake in Australia was higher than usual, and we want to make sure that we have enough doses for everybody who wants one. And one of the interesting things in Australia was that they actually did, I don't know if they used them all, but they procured enough high-dose flu vaccine for everybody over age 65, with the thought that they were going to try to really immunize those high-risk populations with high-dose flu vaccine.
So a few other questions. Someone's asked, with the overlap of symptoms of influenza and COVID, when should we consider Tamiflu treatment? And another person has asked about whether flu vaccines are going to be offered in schools, similar to grade 7 vaccines.
Yeah, I'll take the second question. I mean, I don't know about all the, normally it's public health units who do the school-based vaccination. And historically, there are some that do out of the 34 health units, but most do not. And so I'm not sure if this is on part of their plans for this fall, if even the ones that have done so in the past, if they're planning to continue, because of, I think now things have settled down. So probably, I think it might be feasible that they're not doing contact tracing and all that sort of thing. But I don't know the specific plans for each of the health units. So I think you might want to ask your health unit if they have plans to do school-based vaccination. To answer your first question about Tamiflu, I think for outpatients, we rarely prescribe Tamiflu. I think mostly it's in an inpatient setting that we're using Tamiflu, for people and I guess those at high risk, in the outpatient, it might be warranted. I guess it's tricky because of of when we want to initiate therapy and without having the result. I think it would be, I think if we see a lot of influenza circulating in the community, then it might be okay to just treat on spec. But if we aren't seeing any influenza circulating in the community, I don't think it makes sense, because we don't know if it's one of the other respiratory viruses, and then certainly it could also be COVID, and then Tamiflu will not have any benefit for those patients. So I think I would be probably reserve using Tamiflu unless we have like widespread circulation influenza.
Thanks, Jeff. I mean, I think others in the chat I've noted are also as blown away as I am by that graph. And so really appreciate you sharing it. I'll note that people are active in both the Q&A and the chat. If you're using the chat to post resources or questions, again, prefer the questions to go in the Q&A, but if you're using the chat to post resources, please choose all panelists, all attendees, depending on who you want it to go to. So if you do want the panelists and other attendees to see it, please choose both all panelists and all attendees. There's a question here that was posted. Are you all planning to bring in patients in clinic for flu shots? I do a walk-in clinic as well, so I'm feeling nervous to announce flu shot clinic by me for everybody, considering the COVID restriction protocol taken by our clinic. Or are you going to be selective about your family practice patients only? So I don't know if somebody on the panel wanted to tackle that question.
I can jump in. I think it's reasonable to offer flu shot clinics to everybody. I mean, it's the same as if a pharmacist doing it, or anyone going to any store. Obviously, you want to have some screening mechanisms in place. Say that if you're sick, don't come to our clinic. But I think if with our regular PPE, all the vaccinators should be wearing a mask and face shield. And then the people coming in to be vaccinated will also be wearing non-medical masks at least. And so I think it's very reasonable to be offering it. I think it's no greater risk than seeing our other patients in person. Obviously, this is something that can't be done over the phone, so it's reasonable to have them come in. Like the risk benefit trade-off is favorable to have them come in for this reason.
Well, I can tell you that Toronto Public Health is going to continue to run 4 influenza vaccine clinics 1 day a week each in accessible areas. They will be by appointment only this year because of the COVID restrictions. So I think that idea of running a flu shot clinic and not knowing how many people are going to show up may require us to move to a more booked, or sort of, figure out how many you think you can safely do in an hour, and give people a time or a time zone to come in. I also know that many groups, regional groups, Ontario Health Team groups, are looking at trying to combine resources and run community-based influenza clinics. There's a lot of concern, depending on where your practice is, bringing people up through an office building, or just being able to physically distance people in their existing solo doc or dyad doc offices. So I think it's really important for people to connect with either the local Department of Family Medicine, or if there is an Ontario Health Team in your area, or one that's planning to be an Ontario Health Team, the OMA has a resource that lists all of those and who the contact people are. And I would urge you to reach out to your colleagues in the area and see if you can do something as a group.
Thanks, David. A couple of other follow-up questions. One is, will pharmacies be running flu shot clinics? My understanding is yes, but I'll just...
So pharmacies will be running flu shot clinics, and about somewhere between 300 and 500 more pharmacies than last year have asked to be part of the universal flu vaccine program in Ontario. So more pharmacies than last year.
Great. And then a few people have asked, as a preparation for this winter, would it be a good idea for the COVID center, I assume they mean the COVID assessment centers, to do swabs for flu at the same time they do swabs for COVID-19? As the advice on isolation, length of absence from work, contact tracing info will differ, ? So will it differ? Not sure. So Jeff, you were going to answer that question.
Yeah. So, I mean, I think that's a very good question about what respiratory viruses that we're going to be testing for at the COVID assessment centers. And that's currently under discussion still. I think the issues are that, the more respiratory virus testing that we're doing, it could take away resources from COVID testing because, the PCR machines can only hold so much material. And, so the more specimens that we're testing for other viruses, then we reduce our capacity for COVID testing. So it's a bit of a balancing act. I think the plan is that they're going to save most of that capacity for non-COVID testing for the inpatients and probably less for the COVID assessment centers. But there may be some, and that's still under discussion, so nothing's been finalized yet. So my expectation is probably going to be a limited testing of other respiratory viruses at COVID assessment centers, largely because a lot of people coming into the assessment centers are actually asymptomatic. And you want to kind of go where, you're more likely to find stuff. So people who are admitted to hospital with more severe illness, there's, more, it's more important to know if they actually have influenza than you institute, you start with Tamiflu treatment and all that sort of thing. As for the advice on isolation, and that's, I think it's, practical that, people should stay home and self-isolate until at least 24 hours after a complete resolution of symptoms. So whether it's COVID or something else, if it's COVID, we're implementing a 14-day period. If it's COVID negative, you should still stay home until symptom resolution and then give it another 24 hours as well.
Thanks, Jeff. So I see lots of more questions popping in on the chat. I think there are people who are worried about flu vaccines running out, but I think, David, you've reassured that the government is trying to procure some more, and so hopefully that won't happen. I think Javed Alu posted, can we do flu shots outdoors? And that did seem to be, a good idea. No reason that we shouldn't be able to. I do want to just shift gears slightly, and we will still get back to these questions about flu and flu vaccine, but I also wanted to turn it over to our panelist, Dr. Jennifer Bondi, because Dr. Bondi, and maybe Brian, you can turn off the slides at this point, and we'll come back to the slides. So Dr. Bondi, you have a leadership role in Windsor, Essex, and Windsor, Essex is one of the areas of Toronto that has experienced some of the highest rates of COVID, and I think they were the last to go into stage 3. So tell us a little bit about, the kinds of preparations that you've been doing in Windsor, Essex, and some of the kinds of issues that you've had to deal with in your medical leadership.
Yeah, thanks. You're absolutely right. We have been struggling with higher numbers that have been resolving, I think, a little bit more slowly than other areas of the province. I think it was just within the past couple of weeks that we were finally able to enter into stage 3 with everyone else. I mean, we've been trying to tackle the various issues like everyone has. We're talking about the flu right now as well. Some of the things that are on our agenda for right now, I think, first and foremost, like at the front of everyone's minds with Labor Day fast approaching, is the returning to school and what that's going to look like. So from our Windsor Essex County Health Unit last week released a safe return to school toolkit. The toolkit is geared toward community members, but it is important for family physicians and nurse practitioners to see that toolkit to know where patients may be directed to us and what types of questions they may be asking based on the advice that's being provided. So one of the first instances is that patients, students who are symptomatic are being asked to connect with their family physicians and nurse practitioners. And that's to be expected. And I mean, we've all been dealing with patients with symptoms approaching us since the pandemic has begun and having to deal with it. I would say it's perhaps a little bit different in this situation because we may be getting higher numbers than we have seen. And so it's important to be cognizant of that and know what the plan is going to be. So the testing, there's a new testing document that came out on August 14th and is posted. I apologize, it wasn't in because I didn't have it at the time that we submitted our resources, but I think we've got the link there to it. But it has a specific section on schools from K to 12 and post-secondary as well, and how to deal with those cases specifically. So as far as the testing guidance for schools, it speaks to the symptomatic testing of symptomatic individuals, and that we should defer to the regular testing guidance. And that says that anyone with at least one symptom should be considered for testing based on clinical judgment, factoring in the idea of local epidemiology and potential exposure risk. And so we may not necessarily have to test everyone with any type of symptom. However, we should be considering it. And we're often, as family physicians, in the best position to be able to decide where that's appropriate. That being said, I mean, not everyone is necessarily in a position to be able to assess or test within their own clinics. And so if you are able to do that, that's great. But we want to ensure, of course, continuing that we have appropriate IPAC in place, that there is sufficient PPE, and that if you're practicing in a setting where there are multiple clinicians within the same clinic, that person A knows what person B is doing and person C is doing, so that we're not kind of trying to work on top of one another, because that can obviously lead to some frustration. For people who are not able to test, what's the plan going to be? Will it be similar to what it was for your other patients? So will your local assessment center or testing center be able to accommodate these pediatric patients? Or do you have a specific pediatric care pathway within your community? These are things that I think are being developed across the province right now. These discussions have been happening. And so it's a matter of informing ourselves to figure out where to send these people if you're not going to be following themselves. The other thing I think worthwhile noting is that it's probably not quite the same skill set performing a nasopharyngeal swab on, say, a kindergartner versus a consenting adult. And so if you've not had an opportunity to practice that skill before, perhaps informing yourself so that you have so that you feel confident if that were to arise. And then I think a final point with that is, how are you planning to monitor the cases? Is this something, is public health following the cases? Do they have a pediatrician who's following? Are you going to follow, and how will that be, yourself or a nurse in the clinic? So things to be thinking about. The other piece to this that our toolkit within Windsor Essex spoke to is the clearance. So parents of students, teachers, support staff are being asked to complete questionnaires prior to going into school each day in order to ensure that people who are symptomatic or have had a close contact are not going in. But then they're being asked to follow up with us, the family physicians and nurse practitioners, to determine whether, in some instances, when they can return to school. Of course, this will in part be guided by public health, but they're asking us to step in as well. And so, I mean, some of this is probably a little bit more clear. Symptomatic patients who test positive will be dealt with by public health. Symptomatic patients who have a negative test, though, based on the clearance document that we have from public health, from July 29th, says that one negative excludes COVID, and that but people still have to isolate for 14 days afterwards. Whether that's what is going to apply to schools or not, I'm not sure that guidance has necessarily come out yet, but and maybe someone else can speak to that, but that's based on the clearance document from the 29th. As far as the asymptomatic, sorry, Jennifer, did you want to say something?
Yeah, so sorry, I did
Brian, are you also able to put up the slide 20, quick reference, public health guidance on testing and clearance?
Yeah, this clearance document is a 6-page document, and a quick reference is a sort of euphemistic, I would say, but it's, you know, the lots
I
of
think
small.
I think it used to be 43 pages, so you know. Right.
Yeah. They made it quick. In any case, I have had to go back and back and back to this, so memorizing it is challenging. If you have a negative swab for in school age kid, swab negative, you can go back to school 24 hours after symptom resolution. If you are a contact of a confirmed COVID case, a negative swab is in some ways irrelevant as far as the isolation goes, because you are still to isolate for 14 days after that exposure. So the difference is, COVID positive contact, you have a 14-day isolation, close unprotected contact. So that's a close unprotected contact. It's not a physician who's done a swab on somebody who ends up being positive. That would mean everybody who does swabs can't work. but the individual who has had a close, unprotected contact with somebody who proves positive for COVID, it's a 14-day isolation. The school-age kid who gets swabbed, ends up negative, it's back to school 24 hours after symptom resolution.
Thank you, Jennifer Young. That's really helpful. Jennifer Bondi, I know that you were in the midst of also just finishing up talking about kind of what your the approach that you guys have been taking to support schools in Windsor, Essex. Was there more that you were going to say?
I think that's about it. I think that sums it up. Basically, I mean, I think this new testing document offers us a lot of advice that we didn't have up until very recently. So it's going to help inform the discussion going forward. I don't know if I have, no problem.
I think there's lots of questions that are in there in the Q&A in the chat. And so I know our panelists are trying to type answers to them for sure. And so if you, Jennifer, if you can work away at that with our other panelists, that's wonderful. And I'm going to choose some to answer live as well. I did want to also go, Brian, are you able to go to slide 24, return to school? I just wanted to, share this resource if you haven't seen it. So Jennifer mentioned the resource they've developed at Windsor, Essex, a region of Ontario. I believe I might have said region of Toronto, but I didn't mean to be Toronto-centric if I said that. So yeah, maybe Jennifer can share the guide they've developed, but this is a guide developed by a doctor and teacher couple at the Markham Family Health Team, and we've included that in the chat for folks. I know there's lots of more questions about the flu vaccine, also work notes, and we're going to get to the topic of work notes in a minute. I do know that we had a question that was posted really early in the morning and we haven't got to it yet, so I'm just conscious of that, and I'm going to ask maybe David if he can. We're going to switch gears, and this physician's asked, we're looking for a free, secure method to communicate with patients other than email, where they can send us photos and forms and we can send back completed forms for them. Any options from Ontario Health or Ontario MD? And David Kaplan, are you able to?
Sure. So I don't think there's a free, secure method. I think that, just like any other work related tool, you'd likely have to pay to have something. There are a number of different options. So depending on Dr. Meng, which EMR you're using. So there's options for people using TELUS or for QHR, Acuro, or for Oscar that I know exist. There's definitely ones that are offered by the vendor. There's Ocean that can connect to all three. Some of the options require the patient to register for an account. Other of them don't require, so that you actually are able to send them a message that they respond to securely. So there's a number of different options. I suggest you speak to your vendor or go to your vendor's website and see what's available. But I agree, I think using a secure method is definitely a lot better. And not just that it's better because it's secure, but likely these secure methods actually will integrate the photo directly into your EMR. It'll save you time, it'll save your staff's time, it'll be good for medical legal reasons. So I think that's a great question. I did want to answer it live.
Thanks. So I do want to get to the topic of sick notes and work notes because there are lots of questions in the Q&A about that. So for example, I'm going to pick one here.
Tara, can I jump in?
They're asking me for a letter of accommodation in schools if they're pregnant, diabetic, asthmatic, without a belief that they're high risk for COVID. How are you going about doing that? So Jennifer, Jennifer Young, I'm going to turn it to you. And I know that you also do have a couple of slides speaking to this. So Brian, I wonder if you could bring up the sick notes slide.
So the first sick note slide that I have here is just to highlight there's a difference between illness and workplace accommodation. You are writing notes for your own patient, so their own illnesses. And so a sick note would be if they become ill and you need to write a sick note. The other is workplace accommodation. And this link is from the College of Physicians and Surgeons of Saskatchewan. And we've been in contact with the CPSO about similar sort of guidance for us. that says, that goes over this. You need to do an individual assessment of your patient who has a chronic illness. And unfortunately, if we go to the next, there's a slide that says conditions conditions that put people at risk for severe COVID.
I think that, I don't know if we have that, but the next slide I think is from the OMA. Is that right? Yes. Is this what you're?
No, I think there's another one. Is there not another one? At any rate, if you go to the Public Health Ontario or the Public Health Agency of Canada, the list really is very inclusive. It is things, it will say diabetes, lung disease, hypertension, coronary artery disease. And so your role will be to assess how unstable or severe that condition is, and decide whether a person can safely, if a person has a condition such as this, their workplace will need to make an accommodation for them to protect themselves. With the specific answer around pregnancy, the SOGC, and we've posted that link earlier and in the Q&A, the SOGC has said that an uncomplicated pregnancy is not a reason for a workplace exemption. Complicated pregnancies are, and asthma is it's unfortunately it's not super clear. The evidence would suggest that asthma does not put you at an excessively high risk of COVID complications. COPD probably does, but to your question, Jane, to have a specific, yes, these are exactly the conditions we don't have one central national list that makes it easy for us or easy for the public. It would be great if we could post it across Ontario, and so that workplace and individuals know whether or not they qualify, as opposed to it relying on this discussion with your patient individually. But at the end of the day, it will end up being your discussion with this patient individually. And this is not new. We've been dealing with this as regards our healthcare workers in the course of the pandemic. And we have, so just remind yourselves, you've gone through this conversation before, as people have been asking themselves, is it safe for me to go to work as a frontline worker? And the workplace precautions that are important remain important. I don't know if
I think there's a follow up here, Jennifer. You know, doesn't the work safety depend on accommodations and not just existing conditions? And so are we able to, you know, preclude return to work rather than describing the risk level and asking work to ensure safety given those risks?
So just as
so I was just posting from the Ontario Human Rights Commission. One of my friends is now the associate chair, and the Ontario Human Rights Commission has said, and I posted the link, I think both in the chat and in the Q&A, that employers should be flexible and not overburden the healthcare system with requests for medical notes. Unnecessary visiting of medical offices increases the risk of exposure for everybody. So what they're suggesting is that all employers should take requests for accommodation in good faith. And so that's from the Ontario Human Rights Commission. So theoretically, patients should not require notes from us.
Thank you.
For accommodation.
Yeah. Jennifer, did you want to speak to that OMA communication? That's the next slide.
It's yeah. So
sorry, I think the slides sometimes take a moment to change. So they're basically asking about. So we can get back to that, but I think I do want to. There's a couple of other questions that have popped up into the Q&A. Javed Aladas, what would you do for parents? Isolation of so what would you do for parents of a child who was exposed to COVID at school, especially as while still waiting for the exposed child's results? So are they supposed to isolate as well?
That's the million dollar question. The self-monitoring and safe and PPE use. For example, if you're a physician, but your specific question was around parents. I wish I could be clearer and say, no, that doesn't make sense, because everybody would be at home with their kids. The workforce would be decimated by every sniffly child who has a viral illness. So I'm sorry, I can't be more directive. It would be a case-by-case assessment of the pre-test probability of that child having influenza.
I don't know if any of the other panelists wanted to jump in on that. That's a difficult question. I think this is an example of where we're living in gray. So Jeff, you seem like you have a thought there.
Yeah, I'll give a stab at it. I mean, I think, if your kid has, or like a child's has been exposed to a confirmed case of COVID. So I just want to make sure that that's the situation we're talking about. That child would be put into quarantine. And then, for some period, like probably 14 days. And then, if they exhibit any symptoms, then they would go get tested. Or maybe public health will tell all the kids to go get tested anyway. I think the uncertainty, arises from like exactly when they should get tested. So, we know that there could have been an exposure, but was there transmission? And then there's an incubation period of a few days. So it's hard to say exactly when someone should go get tested, because if you test negative, you don't know if they were tested negative just because they're still incubating and weren't starting to shed virus yet. And so that's why sometimes they will recommend going for a second test, a few days later, to see if you may start shedding. So I think that I would recommend following the protocol where the kids who are in quarantine should be isolated from the rest of the household members. So they should have their own bedroom, their own washroom, that sort of thing, if it's possible. And then to be extra careful, because you don't know if that kid could be shedding virus asymptomatically or pre-symptomatically. So simply monitoring for symptoms may not be sufficient. You might want to consider having everyone in the household wearing masks. I know that sounds extreme, but we're kind of going into uncharted territory. We don't have a whole lot of evidence to guide us here. But these are the sort of prudent things we could try doing. I mean, there is evidence that wearing masks in the households before someone has symptoms can reduce transmission. There's a study in China that found that. So that's sort of my approach to it.
Yeah, I was going to just add to, I think it really depends on the age of the child and the age of the sibling. We have to remember also the siblings in the home. If these are older children, it may be easier to try to get them to self-isolate. If you have the space in your house, where you have another bedroom or another bedroom and bathroom in the basement. Like, I think there are multiple factors here. I think we're going to be asked, or public health is going to be asked about this as these exposures happen. And so we need to sort of think about what are the things that would allow a family not to have to all isolate. I think it's, like Jeff said, it's pretty gray. If you can truly isolate a kid at home, that's probably okay. I remember this happening to me during SARS twice. So I was quarantined 14 days times 2, 17 years ago, and I had a newborn at home with my wife, and I lived on a different floor than everybody else for 28 days. It was a lot of fun. But these are unprecedented times, and ultimately we know household transmission, and Jeff probably can speak to this better than me. We see a lot of household transmission with this virus. And so if we can reduce it, that would be a great thing for everybody.
One last thing I mentioned is like things like environmental cleaning, cleaning your high touch surfaces, cleaning your washrooms, your faucet taps and all that sort of thing is probably like, your fridge door and stuff like the handles and stuff like that would be a good idea.
Yeah. So we have up here just the slide just from the OMA. I think acknowledging what we're hearing today is that this is a difficult situation doctors are being put in regards to sick notes and work notes, and a lot of it is not reasonable. Brenda, can you advance the slides just a couple to the useful COVID-19 websites just before we end? I want to make sure that people know about these websites. The Ontario College of Family Physicians has curated wonderful resources, practical resources, summaries for folks, and the link is there. And I also wanted to give a shout out to the Center for Effective Practice that has an excellent COVID-19 resource center and is actually looking for input from family doctors on what resources would be helpful. And so I think they're on the call actually today and listening to all of the questions you have, but we've also sent out a direct link to a survey. So there's a survey link in the chat, and if you want to give them some input as to what kind of tools would be helpful. We have a few more minutes, so we won't be able to get to all of the questions. And so what I ask people is that if you see a question there that you really like, just click on the thumbs up and I'll advance it. Jennifer, you were going to say something, and then I was going to go to one more question.
Yeah, the most recent letter from me and the OCFP, the one that was sent out on Wednesday, summarizes a lot and has a lot of what we have talked about today, and has links to many of the links that we have referred to, as well as this presentation will be available for people after.
There was one other question that I asked. I agreed to answer live. This was a question earlier about.
Yes, I think there were two related questions. There was one related to demands for. They're both, I think, related to testing. One is, will there be testing kind of in schools?
Right.
And the other is sort of, do we have the capacity really to test all these kids if they have symptoms?
Yeah. So I'll answer both, I guess. So the first is, public health's requirement, public health's responsibility, I should say, is for outbreak management. They're not responsible for testing. And so it's going to really be up to the individual assessment centers if they want to have a mobile approach or not have a mobile approach. In some areas of the province where, it's too far, there, certain family practices or CHCs will likely be doing testing. On the question about can we actually deal with that onslaught of testing? So I think it's a really interesting question. I heard yesterday in the province, there's about 5% of children that are absent from school every day. That's of 2-point-something million children. So now we don't know why they're absent. I'm not sure they're all absent because they have COVID or historically COVID-like symptoms. And I think that's one of the things that we're trying to really get a good understanding of is who do we really need to test? If a child vomits once at home, do you automatically tell them to be tested, or do we think that maybe they had something bad to eat the night before? And so I think in the next 11 days, plus a few more, considering it sounds like some school boards are delaying opening, these are questions that we're going to have to really get some great answers to. Clearly, even with a test capacity, if we go up to 50,000 tests a day in the province, testing 5% of 2 million people every day would be not sustainable. And so I think we have to have a very appropriate testing strategy for children. I think one of the questions obviously is also going to be, and Jeff maybe can speak to this, if you have a positive case, at what point do you start, and I think he sort of mentioned, at what part do you start testing? Do you blanket test everybody in the class or versus wait for them to develop symptoms? And that's really the guidance I think we need provincially for our assessment centers. And to be honest, for us as clinicians, because I think that patients are going to listen to us as their family doctors and nurse practitioners. We have a lot more credibility than, I work for the government, so I'll say the government, but I think that joint messaging between primary care and the government is going to be so important. We can't forget that there's always a spike of asthma in September, right? There's the September asthma spike. So we're going to have a lot of kids with symptoms, and we're going to have to tease out what are we testing versus what aren't we testing. It's not going to be easy.
Thanks, David. So I see that there's a lot of Q&A still there, and I apologize that we haven't been able to get to any, but I do see that we've answered over 30 of your questions in the Q&A, and plus probably another 5 to 10 in the chat. You know, we're going to be organizing our next community of practice on Friday, September 18th, and I think those questions will still be there, a lot of them, and we'll so stay tuned for that opportunity. And we have a survey following this webinar where we're going to ask you what topics you're interested in discussing. So if you just want a continuation of this one, just please say so, because I think you know, preparing for the fall is going to continue for a while, and it's going to be unclear, I guess, for a bit how it's going to work, what we're going to be seeing in our clinic. Is it going to be in Australia like? Is it going to be Australia like with low levels of flu? Let's hope so. Let's hope that you know, we do get some clearer guidance around some things like work notes. And I think, you know, I saw in the chat people wanting how do you isolate or quarantine within a home? So we see there's some, you know, practical tools that people want to help support their patients. So we'll be reconvening September 18th. In the meantime, check out our website where we will post on the previous sessions, and we'll be posting the webinar from this session in case you want to re-review it, and we'll also be posting all of the links.
And Tara, just to say, the OCFP, we are really trying very hard, as is trying very hard to keep up to date and keep the links fresh with any new guidance. So our COVID guidance on the OCFP site and the Center for Effective Practice as well. Those are 2 locations that you can go to for updated information prior to the September 18th session. So yeah. keep checking out these 2 the resources that you had put on the slide prior to this.
And we are grateful for the questions, because they will help to inform OCFP and the Center for Effective Practice and ourselves as we move forward to trying to develop practical tips and tools for you. So thank you everybody for joining us today, and have a good Friday. Stay safe, stay well.